Hello, friends. I'll be giving a overview on this quite important topic, sepsis mimics, which was given to me to deliberate in Lucknow in King George Medical College on 26th July 2025. So if you honestly look into this, if you look into the literature, there's more of differential diagnosis for sepsis mimics. So obviously, when you dwell into each condition of the sepsis mimics, any condition you think that you would encounter in ICU could present with a few features of sepsis. And very often there is a huge overlap between infective and non-infective sort of conditions. So we look into what is the evidence and how we distill out and crystallize certain salient aspects which may help us delineate the patients who are real sepsis and who possibly are not sepsis. So we look into it and have some take-home messages. So when you look into the older definition of sepsis, so obviously they had SIRS as a criteria, although now we do not use it, but still it constitutes an important sort of a dimension of identifying sepsis mimics. So obviously in SIRS you have temperature, heart rate, respiratory rate, white cell count, and CO2. And we call it sepsis when two of these SIRS have associated infection. The reason why we need to delineate these two is because when it is associated with infection with features of SIRS, the mortality is around 10%. And when this is associated with an organ dysfunction and hypotension, which is evidenced by lactate more than 4, then the mortality jumps up to 40%. And if this is persistent and not reversing with whatever interventions that you're putting in place, then the mortality is 50%, and we call it as septic shock. So this was the characterization of different forms of sepsis. So after this, then the sepsis 3 definition came, which tried to de-emphasize on this whole concept of SIRS and endorsed by 31 societies, which basically said we have to identify someone as sepsis. There should be life-threatening organ dysfunction due to dysregulated response of host to the infection. That infection could be bacterial, viral, or fungi. And the mortality was put as more than 10%. And if this was associated with septic shock, where they defined when there is a life-threatening organ dysfunction needing vasopressors to maintain MAP more than 65 with lactate more than 2, mortality goes up to 40%. So this is largely accepted by around 35 societies at this point of time. And then they came out with this particular aspect use of which is now de-emphasized and sort of debunked as a criteria, as a prognostication or screening tool where someone has altered mental status with tachypnea more than 22, like which was one of the component of SIRS, and systolic blood pressure less than 100. If they have two of these, you could call it as some patient who you would want to do the screening for sepsis. So these were some of the criteria. So when you look at this sort of a conundrum, even if you apply sepsis 2 or sepsis 3, which is life-threatening organ dysfunction due to dysregulated host response to an infection. This organ dysfunction can happen in lot of other conditions, like the typical thing that we tend to see is pancreatitis or polytrauma and multiple various other conditions which we will talk about. So when you talk about the other places where we call it as sepsis, so what we mean is there is a infective organisms, but we there can be infection due to viral, and we don't need to throw antibiotics for this, or there can be SARS due to pancreatitis burns, we don't need antibiotics, or it could be transfusion, or it could be drug related organ dysfunction, or it can be non-infectious. You have a severe subarachnoid hemorrhage, they can present with organ dysfunction, but you don't throw antibiotics at this. Or there can be progression of underlying chronic diseases, especially malignancy or autoimmune conditions, which lead to organ dysfunction, and we do not intend to throw antibiotics. So, and only 40% of real sepsis, where there is an infection which is triggering of organ dysfunction, 40% are culture positive. So, rest of it is hard to pick up, and these cultures can only act as an adjunct. So, what we're trying to say is there is a whole lot of clinical acumen that needs to be put in place, and maybe some other biomarkers, some other entities to determine the establishment of sepsis as a diagnosis. And throwing antibiotics for all these non-infective conditions would tantamount to a medical malpractice is something that we can conclude. So when we talk about sepsis mimics, any disease, be it an infective trigger or a non-infective trigger, there is a complex physiological conundrum that gets activated. There is a whole lot of a tsunami storm and cytokine release that happens, which leads to fever, acute phase reactions, and this leads to a lot of disturbance in the endocrine and immunological homeostasis that tend to maintain the decorum in the body. So this is the typical sort of a pathway that happens. And when we say why organ dysfunction happens, there needs to be some sort of an harmony or symphony between pro-inflammatory cytokines and anti-inflammatory. When there is a gross imbalance between these, and why does this imbalance happen? Because there's a lot of host factors that determine the imbalance between pro-inflammatory and anti-inflammatory. It could be age, it could be comorbidities, it could be the type of underlying intervention, drugs, and the source of infection. So all this would determine where there is a sort of a dissonance of the balance between the pro-inflammatory and anti-inflammatory cytokines. So when we talk about what are the other conditions which sort of mimic this life-threatening organ dysfunction due to dysregulated host response, it could be a seizure disorder which leads to organ because we see lactate going up after seizure, or it could be a massive intracranial hemorrhage or subarachnoid hemorrhage where you see there is an acute kidney injury that sets in, or there can be severe tachycardia that sets in, or there can be myocardial dysfunction that sets in, or autonomic dysfunction, or spinal shock. And spinal shock behaves like shock as a warm shock with a warm peripheries and organ dysfunction. And we can sort of stratify them system wise. In cardiac, we know that cardiogenic shock and heart failure, or they all can present with organ dysfunction, MI, or cardiogenic shock, or trachea brady syndromes, like you would have seen very often someone with atrial fibrillation with fast ventricular rate, especially in elderly, it leads to sort of physiological disturbance and there can be hemodynamic decompensation that happens. And we see this very often. So all this can lead to sort of a condition which mimics sepsis or pulmonary. There can be aspiration, not necessarily there is an infection which leads to organ dysfunction. There's hypersensitivity pneumonitis or acute exacerbation, severe exacerbation of COPD, interstitial lung disease, ARDS. All these are referenced as conditions which can mimic sepsis. Or if you come to GI, underlying GI malignancy, cholecystitis, pancreatitis is the typical non-infective conditions which presents with multi-organ dysfunction and features of sepsis conundrum. Or it can be ischemic bowel, which is again a common sort of a condition which manifests with organ dysfunction. Or it can be colitis, inflammatory bowel disease, so on and so forth. Any of these bowel, and I always say abdomen is like a Pandora's box, and anything that happens in abdomen can mimic various other conditions, and it is very hard, very pertinent and important to ascertain the underlying cause by advanced imaging to determine. So these are some of the conditions which can mimic as sepsis. And hematological like APLA, tumor lysis syndrome, hemolysis, and hemophagocytic lymphohistiocytosis, which we typically see as a sequel of viral infections, typically presents with sepsis mimic. Or it can be endocrine. We have seen thyroid storms presenting as multi-organ dysfunction or myxedema coma, because mortality in myxedema coma is very high. Post-surgical sort of a SIRS response, and drug-related Steven-Johnson's erythema multiforme, gout, or vasculitis. Alcohol withdrawal itself can present as a sepsis mimic or transfusion reaction. And there are adrenal insufficiency, burns, or any hematoma or any collection anywhere in the body, or venous thromboembolism. All this can typically lead to sort of a SIRS response where there can be a smoldering sort of a temperature, smoldering sort of a tachycardia, smoldering sort of a tachypnea, and raise in the counts. All this can happen with any of these sort of a conditions. So these are some of the differentials, and there are drugs also like atropine, and some of these drug reactions due to penicillin, imipenem, vancomycin, these are commoner drugs that we tend to use in ICU, which can sometimes lead to drug reaction. And phenytoin is notorious to cause a drug reaction, which can lead to severe drug reaction, leads to organ dysfunction. So these are some of the differentials. So friends, you don't need to memorize this. Go system wise. Any condition that you think that you would deal with an ICU, necessitating ICU admission, can present as a sepsis mimic. And you go system wise, you can elucidate and enumerate so many other conditions. But the question is, how do we delineate true sepsis from these sepsis mimics? So there are, and we have to look into evidence. We are all evidence-based people. So the key aspects that have been identified is look into the history, how the history, still the basic clinical acumen remains the focal quintessence to recognize and delineate between this SIRS or in the sepsis and sepsis history. Get the history, do a proper clinical examination. These two are very, very valuable in trying to delineate between sepsis and sepsis mimics. Temperature, we look into the evidence, whether what is the relevance of temperature in trying to delineate between sepsis and sepsis mimic. And biomarker, procalcitonin, we look into the value of procalcitonin, and blood cultures. These three have some evidence to try and decipher between sepsis and sepsis mimics. So when we look into the evidence, so we know the signs and symptoms of infection and non-infection are similar. Procalcitonin can be used as a good sort of a data. Some of the landmark trial is there is a prorata trial done in 621 ICU patients where when they use procalcitonin-guided therapy, so the days without antibiotics, as you see, was more, which is good, and outcomes were better. And this was another trial, that meta-analysis of 11 RCTs, where if you use procalcitonin to guide antibiotic therapy, so mortality was significantly less and the antibiotic duration also was less. And what they've shown in this particular study, Ranjik, is if patient is hemodynamically stable, delayed initiation of antibiotics, in fact, has shown to reduce mortality and increase the appropriateness usage of antibiotics and reduce the duration of antibiotics. So which means to say, you can exercise caution and not jump, because once you give antibiotics, it means that you have made a diagnosis of sepsis. So there could be another conditions which you can sort of decipher when you wait without starting antibiotics. You look for other conditions. So that is the whole essence as to why you should possibly wait. And by not, so this is just to, if you identify sepsis mimics, obviously you will reduce the cost, reduce the antibiotic resistance, and possibly reduce the mortality, and you would avoid the sacrilege of 3Ds. And this is another most recent sort of a Procal trial called Progress trial, which was done in 266 patients, where in 125, the antibiotic therapy was chosen based on the procalcitonin as opposed to the standard. And they found the infection-related adverse events at day 180 was significantly less where procalcitonin was used. And 28-day mortality also significantly less, and duration of antibiotic was less, and the cost incurred also was less. So sepsis, determining the antibiotic sort of a usage guided by procalcitonin, showed reduction in infection-related adverse events and reduced 28-day mortality. So there is ample evidence to suggest that you can use procalcitonin as a tool to sort of delineate whether it is infection-related sort of a organ dysfunction or a non-infection-related organ dysfunction, which we call it as a sepsis mimic. So procalcitonin is a tool, has a good evidence that you could use it, and it could use to reduce 28-day mortality, because the Harangic et al., which came in Lancet, so if you give inappropriate antibiotics for a sepsis mimic, it can increase the mortality. What about temperature? Can temperature guide us? So this is an evidence which came in JAMA in 2012, Coburn et al., where they showed if temperature is more than 37.8 degree, there is a likelihood ratio of sepsis, where if you see the likelihood ratio is 1.5 and confidence interval was statistically 6. So so in ICU, if you see a temperature like we have TBIs, we have subarachnoid hemorrhage, or we have intracranial bleed, anything to do with the brain, you see a smoldering temperature of 100, 100.8, don't throw antibiotic. But even in my clinical practice, if there's a huge spike of 101 or 102, then we pay attention to it and possibly think there is possibly underlying infection and we initiate antibiotics. That's what these studies have shown. And this is very important. This is where clinical acumen, if there is chills and rigors, this study has shown that likelihood ratio of sepsis is very high, 4.7. And if you see confidence interval was significant, which means if someone has temperature and a nurse comes and tells you there's a huge temperature spikes and there is some sort of a chills or shivering that is happening, pay attention to that. Possibly that is sepsis. And that's what has come out from this particular study that came in JAMA. What about blood cultures? And there are this study which came in NEJM looked into, there are certain factors that predict positivity of blood culture, indicating that it is possibly sepsis, where they have looked at one major and two minor criteria. Major is if you have suspicion of infective endocarditis or temperature more than 39.4 degree, one major, if you fulfill, there is a likelihood blood culture is positive, or if there is an indwelling catheter. If one of these major and two of the minor, what are the minor? SIRS, all the SIRS criteria, temperature more than 38, age more than 65, systolic blood pressure less than 90, WBC more than 18K, creatinine more than 2, chills plus 4. So two minor and one major, if you have, very likelihood there is a positivity of blood culture being positive was shown in this particular study. So when we look into that sort of an image I showed, a good history, good clinical examination, procalcitonin has a good value, temperature, if there is a huge spike, that has a predictor, and blood, there are predictors for blood culture. If there is an indwelling catheter, if there is a huge spike, with two of the minor criteria where white cell count creep has happened, chills and rigors have happened, or age more than 65, so on and so forth, you can sort of reasonably convince yourself that there is possibility of underlying sepsis. And this was a very interesting study which came only last year, where they have done a retrospective study to see how many of the patients, it's a retrospect where they believed that were treated as sepsis when on the contrary they were sepsis mixed. It's a beautiful study, more pertinent to my talk here, which came from Sweden. This was a retrospective study done over 3.5 years, where they used this very complex sort of a tool called Linder-Mellhammer criteria. So I request audience, if you Google this also, you will not find too much information on what are the criteria, because the criteria was devised to source specific criteria. So for UTI, they have a different criteria. For CRBSI, they have a different criteria. For abdominal infection, they have different criteria. But essentially, the Linder-Mellhammer criteria is when there is evidence of infection either by microbiology or imaging or clinical, or when there is a SIRS response, organ dysfunction, or exclusion of other causes. They took this as they were the key dimensions of defining the criteria. They had 2,664 patients, and 25% of the patients were sepsis mimics where they gave antibiotics. And in that 25% who was sepsis mimics, there were two which were strikingly found to behave more as sepsis mimics in this particular Swedish study. One was cardiac failure, acute heart failure, typically behaved like sepsis mimics where they had to give antibiotics. And the second is non-specific respiratory failure was something that commonly behaved as a sepsis mix. And CRP in their study showed moderate discriminatory power with AUROC of 0.7. And when you look at their data, as you said, 25% was sepsis mimics, and antibiotic was given more than 4 days in these 25% of these sort of a patients is what was shown in the study. So now, do we have any other tools to try to delineate? So there is a acronym that is devised called the Lucas to identify, so that it gives some sort of a direction and navigation to exercise your clinical acumen to pick up the source of infections. So Lucas is an acronym. L stands for look into the lung for any sepsis mimic that may be present, which is it could be aspiration, it could be ARDS, it could be hypersensitivity pneumonitis, it can be ILD, so on and so forth. And U is look for any urinary source for either infection or as a non-infective cause, and look for heart to look for the source of infections, and look for central nervous system to look for meningitis, look for abdomen as a source when you have to delineate between sepsis and sepsis mimics, and look for any bony joint, seronegative arthritis, or any joint, any septic arthritis, so on and so forth. Look for spinal shock, and S is for skin and soft tissue infections. Look for any CVC or cellulitis. So this is a very easy acronym to remember, to try and make sure that you don't miss out on any source, so that you have this acronym, so that you are very systematic and don't miss out on any source that may be the cause for your underlying sepsis, and to differentiate and delineate from the sepsis mimic. And surviving sepsis also says, when you say sepsis, where it is dysregulated, life-threatening organ dysfunction, dysregulated response to the infection, you have to identify the source and act upon the source within 12 hours. And you need to intervene to eliminate the source if it is feasible with least physiological upset, like typically if there's CVC source, you have to remove it. So, which is very clearly emphasized. So, putting it all together, the quintessence of trying to delineate sepsis and sepsis mimics is a good clinical acumen, good clinical history, good clinical examination. Try to integrate with all the monitored variables, whether he's tachycardic, whether the tachypneic, whether there is hypotension, so on and so forth. And look into the lab variables. There can be biomarkers, procalcitonin, look into the CRP if you have done, and look into the imaging and look into echocardiogram, integrate all these variables to try and delineate. This remains the essence of the tools that you have to delineate. So look into the temperature. Temperature is important. Look into the biomarkers. Procalcitonin is important. Look into the total count. Look into the predictors of blood culture that may be positive, good history, clinical. If you remember these 5 aspects, I think you would have done a great deal of service in trying to delineate between these two. And what are the future? What is the future hold good? AI is coming. So there are already tools called AI sepsis expert, which tries to integrate your sort of a monitored variables map and all the information that are in the records, which is able to predict sepsis 4 hours prior with a AUC of points. So we have now advanced tools to help you to try to integrate all these variables and predict sepsis better. Then there is this SERA tool, which is algorithm sepsis early risk assessment. Once intensivist 2 hours in advance of possible sepsis. It takes in vital signs, lab data, and all the hospital record, and it outscored clinical examination with QSOFA with SIRS. This study came from Singapore with AUC ROC of 0.94. So we have now advanced tools. So these algorithms possibly could be incorporated to have more precision in trying to recognize sepsis and delineate it from sepsis mimics. So the take-home message is understand the definition of sepsis, screen the patients for sepsis, and have a system-wise understanding of differential diagnosis of sepsis mimic. You can use Lucas criteria, and these 5 remain at the fulcrum of having a good clinical acumen in delineating between sepsis and sepsis mimics. And remember, Lucas and AI are in place. So you can use, if AI algorithms are available, incorporate them and try to recognize sepsis and save more lives. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website, www.drpradeeprangappa, to rehead to this lecture. So thank you. Thank you, one and all.